The main outcome of performing AMS interventions in a healthcare facility is behaviour change in prescribing practices and responsible use of antimicrobials. The healthcare facility core elements are essential to enable AMS programs and interventions. A SWOT analysis highlights barriers and enablers to implement an AMS program. The Healthcare Facility AMS Action Plan provides an overview of the facility AMS program with overall goals. Implementing evidence-based AMS interventions to change prescribing behaviour means taking into account factors that influence prescribing and use at the levels of facility, department, ward. There are two types of factors to be considered in developing an effective facility AMS program and action plan: extrinsic and intrinsic factors. Extrinsic factors are structural and organisational factors, which are addressed when developing a facility AMS action plan and program. Intrinsic factors may also influence antibiotic prescribing behaviour and need to be addressed. Examples of intrinsic factors include perceiving AMR as a threat, fear of losing a patient, belief that broad-spectrum antibiotics are effective and low risk, influence of a senior physician's preferences, physician autonomy in prescribing what they think is best, uncertainty due to inadequate microbiology services. When performing AMS interventions, implementation requires that they be tailored to address the different factors that may influence antibiotic prescribing and use in a specific context. It is important to set goals for the AMS action plan. There may be more than one AMS goal in a facility. For example, in a larger facility, a surgical department may have different priorities to a medical department. Each department sets their own SMART, specific, measurable, achievable, relevant, time-bound goals. In a smaller facility, the overall goal identified in the AMS action plan may be sufficient, and the same AMS interventions may be implemented over the whole facility. When identifying goals or targets, it is helpful to review areas that need improvements in antibiotic prescribing. Here are 9 common, very generic areas for improving antibiotic prescribing. They include over-prescribing, overuse of broad-spectrum antibiotics, unnecessary combination therapy, including certain fixed-dose combinations, wrong antibiotic choice, wrong dose interval, wrong duration, wrong route, delayed administration. In the case of overprescribing, antibiotics are prescribed when not needed. For example, fever without evidence of infection, asymptomatic urinary tract colonization, viral infections, malaria, inflammatory conditions. More broad-spectrum antibiotics, such as watch and reserve antibiotics, are prescribed than are necessary. For example, for surgical prophylaxis. In unnecessary combination therapy, including certain fixed-dose combinations, multiple antibiotics are used, particularly with overlapping spectra, and in combinations that have not been shown to improve clinical outcomes. Sometimes the wrong antibiotic or antibiotics are prescribed for particular indications or infections. Then there are cases when antibiotics are prescribed with the wrong dose, for example, over or underdosing. The next area for improving antibiotic prescribing is wrong dose interval. When antibiotics are prescribed with the wrong dose interval, for example, too much time between doses. Another issue is when antibiotics are prescribed by the wrong route, for example, IV instead of oral. Antibiotics are sometimes prescribed for the wrong duration, for example, antibiotics prescribed for too long a period, such as prolonged surgical prophylaxis when not needed. Delayed administration is another issue. when the administration of the antibiotic or antibiotics is delayed from the time of prescription. For example, repeat doses are not administered in a timely way, which is critical in the case of septic shock and other serious infections. Tackling these common areas for improving antibiotic prescribing calls for a systematic approach to implementing AMS interventions. The Quality Improvement Model provides a systematic approach for the AMS team to set SMART goals for change, tailoring and implementing AMS interventions and assessing their success. The Quality Improvement Model follows the continuous improvement cycle: plan, do, study, adjust and repeat. Here are some of the key questions to address when applying the Quality Improvement Model for AMS interventions. What are you trying to achieve? Set a goal for change in antibiotic use that is SMART. How will you know that the change is an improvement? Determine what quantitative measures to use to show improvement, for example, through measurements. What changes can you make that will result in improvement? Not all changes are an improvement. Identify the behaviour changes that will result in improvement and tailor the AMS intervention accordingly. Let's look at the Quality Improvement Model in some more detail. The first step is to prepare. Map possible enablers such as AMS champions and barriers in the unit. Obtain managers' and champions' commitment to change. Prepare to talk about AMR, the unit's antibiotic use and what can be done. In the planning step, Step 2, present the AMR problem, challenges in antibiotic use and discuss what we can do. Set SMART goals for changing the unit's antibiotic use. Decide on AMS interventions, how to implement them and how to measure change. In the next step, Step 3, do. Perform the identified AMS interventions. For example, education, ward rounds and audit and measurements. An AMS review form might be helpful for this step. In the following step, Step 4, study. Analyse the measures such as process and outcome measures. What do they show? Evaluate AMS interventions and their implementation, to be continued or changed. Prepare to discuss the results, AMS interventions and implementation with the units. Review resource use and costs and determine whether there have been savings. In Step 5, adjust. Discuss the results and AMS interventions with the unit. Agree on any adjustments to the AMS interventions, implementation and measurements. Follow up with a continuous improvement cycle. Plan, do, study and adjust. This model can be applied at the facility level in small facilities or at departmental or ward level in larger facilities. Just remember that it is important to implement AMS interventions in a stepwise approach. Build on existing structures and reporting. Maximise teamwork. Encourage champions and clinical staff, including prescribers, to participate. Start small and keep it simple and doable. AMS interventions can be performed in all types of healthcare facilities. However, it is important to note that the interventions are aligned with local needs. They should address areas where observations or data suggest improvement and/or where the outcomes of the implemented interventions are measurable. In facilities where many core elements are not yet in place, basic interventions may be a place to start to improve antibiotic prescribing. These interventions can be implemented one at a time or in a bundle. Basic AMS interventions include 1. Educate prescribers and health personnel involved in antibiotic use. 2. Develop and update a standardized medical record and medical chart to ensure that information on patients' medicines is all in one place. You can download a standardized medical chart. 3. Review whether patients who receive antibiotic treatment have written indications. 4. Review antibiotic treatment for patients prescribed 3 or more broad-spectrum antibiotics. 5. Review the dose of antibiotics prescribed. 6. Review surgical antibiotic prophylaxis where it is prescribed for over 24 hours and where a single dose is appropriate. 7. Develop local guidelines for surgical prophylaxis and treatment of common clinical conditions such as community-acquired pneumonia, UTIs, skin and soft tissue infection. 8. Work to ensure leadership and identify expertise in infection management. 9. Improve the supply and management of medicines, including essential antibiotics, for example, by establishing a Drug and Therapeutics Committee. 10. Work to establish basic microbiology laboratory facilities. 11. Work to establish regular surveillance activities, for example, AMR, AMC, healthcare-associated infection surveillance. Next, we'll see how to move beyond the basics. How to move beyond basic AMS interventions. To fully benefit from an AMS program, facilities should aspire to put AMS core elements for healthcare facilities in place. Core elements include securing essential antibiotics, treatment guidelines, and an AMS team. What applies to larger healthcare facilities may not be suitable for smaller healthcare facilities. For instance, smaller healthcare facilities may collaborate with other healthcare facilities on certain areas, that is, developing guidelines, expertise, microbiology laboratory services, etc. This will facilitate the necessary structures, expertise and skills to implement more AMS interventions. Additional AMS interventions include improvement in antibiotic prescription, related to treatment and surgical prophylaxis, which will also help improve dispensing and use. For appropriate antibiotic treatment, the following are important. Review the indication. Is it a bacterial or viral infection? Is it colonization? Is there inflammation? Is microbiology testing needed? To guide prescribing, what is the probable pathogen? Is empirical treatment needed? Is it a severe disease? Are there any comorbidities or allergies? While reviewing, confirm whether it is the right indication. Were the right antibiotics prescribed? Is there a need for IV to oral switch? What were the microbiology results? Based on the review, you might go back to the prescribing step and change the prescription. Finally, stop the treatment based on the treatment duration. Similarly, for appropriate surgical prophylaxis, the following are important. Review the indication. What surgical procedure is being undertaken? To guide prescribing, what is the right antibiotic or multiple? What is the right time and right duration? Are there any risk factors? Finally, stop antibiotic treatment. Generally, antibiotic prophylaxis should not be prescribed for more than 24 hours after surgery. Different types of AMS interventions have been proven to be successful to improve antibiotic prescribing. To bring about change in antibiotic prescribing, a bundle of AMS interventions is often implemented. There are different types of AMS interventions. 1. Persuasive education, which includes educational outreach, formal or informal. 2. Persuasive feedback, which includes audit and feedback activities, real-time, either written or oral, or retrospective. 3. Restrictive interventions, for example, pre-authorization of targeted antibiotics, and finally, 4. Structural. It may be useful to change interventions over time. Facilities need to prioritize interventions based on resources available and the identified goals. Persuasive educational interventions include educational meetings, for example, basics on antibiotic use, case-based discussions, morbidity and mortality, significant event analysis, lectures on specified topics. Distribution of and training on educational material, for example, training on clinical practice guidelines. Using local key opinion leaders, champions, to advocate for key messages. Reminders provided verbally, on paper or electronically. AMS e-learning resources made available to all healthcare personnel. AMS education as part of continuing medical education. Persuasive feedback interventions include audit with feedback to prescribers on their prescribing practice. AMS as a component of ward rounds that includes real-time feedback with an educational component. Patient handover meetings between 2 shifts with real-time feedback by consultants. Local consensus processes for changes in antibiotic treatment or surgical prophylaxis. Restrictive interventions include formulary restrictions, restricted prescribing of identified antibiotics, such as needing expert approval prior to prescription. Here you can download a sample of a pre-authorization form. Compulsory order forms for targeted antibiotics. Automatic stop orders, for example, after a single dose of surgical prophylaxis. Selective susceptibility reporting from the lab. Structural interventions include rapid laboratory testing made available, therapeutic drug monitoring. Here is a comprehensive list of AMS interventions for improving antibiotic prescribing practices. Let's start with examples of persuasive education interventions. Education includes formal or informal teaching and training to engage healthcare workers in improving antibiotic prescribing, dispensing and administration practices. This can be achieved through basic and continuous education of clinical staff, clinical case discussions, classes and regular sharing of information, reminders and AMS e-learning resources. The advantages of this approach are that it can be performed by well-informed healthcare workers in informal settings, for example, during ward rounds. It is necessary for better adoption of most AMS interventions. It results in improved prescribing behaviours when combined with other AMS interventions in a bundle. The disadvantage is that you may only have a few AMS team members, which can pose a barrier for formal training of healthcare workers. Next, treatment guidelines, which can be national or facility-based, provide treatment recommendations for common infection syndromes, based ideally on local susceptibility data, if available. This can be implemented using the WHO Manual for Developing Antibiotic Policy Guidance. The advantages are that it leads to improved, standardized care for common infectious diseases, helps prescribers improve antibiotic use, and decrease cost and length of stay. However, the disadvantages are that it requires broad dissemination through multiple formats and channels to ensure uptake. Surgical prophylaxis guidelines include facility recommendations for common surgical procedures. It can be implemented by adapting surgical prophylaxis guidelines to local needs, providing antibiotic choice, dose and duration, disseminating guidelines through posters in the operating theatre, leaflet, apps and electronic platforms, and placing automatic stop orders. The advantages are that it can help ensure timely administration and stop of appropriate antibiotics, significantly reduce surgical site infections, easier to implement than other guidelines. This is a low-hanging fruit intervention as, once the process is optimized, only periodic monitoring and feedback are required. The disadvantage is that it can require coordination and collaboration of many disciplines in the facility. Now let's move to examples of persuasive feedback interventions. Audit with feedback includes assessment of prescribed antibiotic treatment with feedback on antibiotic treatment, prospective, which is preferred, or retrospective assessment of antibiotic therapy in inpatients performed by trained healthcare workers or AMS team members. The procedure is covered in Topic 4 in this module. The advantages are: it is essential to prescribers' education, provides specific feedback on what antibiotics they prescribe and how they prescribe them. It identifies antibiotic prescribing challenges in the unit and shows the impact of AMS interventions on antibiotic prescribing and use. For example, de-escalation duration. Data may include information on indication for treatment, prescribed antibiotic or antibiotics, dosage, interval, administration route, timing of administration of first dose and duration if collected after stop of treatment. It can be performed from very basic, where only indication and antibiotics prescribed per patient are audited, to more advanced. The disadvantages are that it is time-consuming and can be perceived as intrusive. Ward rounds have the opportunity to undertake real-time assessment of antibiotics to be prescribed, or which are already prescribed, with instant feedback to prescriber. How can this be done? Assess appropriateness of prescribed antibiotics for all inpatients or a group of patients, ICU, surgery, etc., and provide real-time feedback. AMS members do ward rounds, preferably with clinical staff, providing oral or written feedback. Issues to consider are redundant therapy, antibiotics prescribed, compliance with guidelines or microbiology test results, dose optimization, IV to oral switch and duration. The advantages are that it provides real-time feedback on inpatient antibiotic treatment and training of prescribers, can be performed by clinical experts who are not AMS team members, for example, on handover meetings between shifts. The disadvantages are that ward rounds are often performed by AMS teams and time constraint can be an issue. Frequency of ward rounds depends on human resources. And finally, let us review an example of a restrictive intervention. Automatic stop orders are stop dates that are automatically applied to an antibiotic order when the duration is not specified to ensure that antibiotics are continued no longer than necessary. Here's how it can be implemented. Automatic stop orders are mostly used for a single dose of surgical antibiotic prophylaxis or prescribing some antibiotics. They are useful in small facilities and with limited pharmacy staff. They should be used only in a context with good control mechanisms to avoid unsafe treatment interruptions. Nurses can play a role in alerting the attending physician. The advantages are that it is a simple intervention, considering the high burden of antibiotics unnecessarily used for surgical prophylaxis. The disadvantages are that IT is needed, which is often missing. Unintended treatment interruptions can occur if not properly supervised by the AMS team. Some of the key takeaways are that the ease or difficulty of implementation depends on the availability of local resources and competencies. Facilities need to prioritize interventions based on resources available. Local or regional networking and resource sharing, including e-learning, might help in implementation. Prospective or real-time audit with feedback involves the assessment of antibiotic therapy by trained individuals who make recommendations to prescribers in real time when therapy is considered suboptimal, for example, on ward rounds. A prospective audit may be prioritized over a retrospective audit as it provides real-time feedback to prescribers. Prospective audit with feedback may be performed alongside clinical personnel on ward rounds, providing oral recommendations for changes in antibiotic treatment in real time. Alternatively, the physician and/or pharmacist in the AMS team may perform ward rounds on their own, providing written recommendations for changes in antibiotic treatment. Retrospective audit with feedback is a method of collecting antibiotic data to evaluate the impact of AMS interventions. For example, baseline and follow-up data on antibiotic use, assesses antibiotic therapy in hospitalized patients, often coordinated by a physician or administrator, but performed by pharmacists and/or nurses. Antibiotic audit data are collected as follows. At baseline, to identify areas for improvement of antibiotic prescribing for the whole hospital, a department or ward. For a defined period of time to evaluate any improvements. To provide regular and structured feedback, both on the quality and quantity of antibiotic prescribing and use to prescribers. The benefits to clinic staff are that it gives an opportunity to discuss their prescribing practices, identifies priority areas for changing prescribing behaviour, enables goal setting to improve prescribing behaviour at the facility, department and/or ward level. When selecting one or more infections for audit, a key question is, to what degree are infections treated according to guidelines? The audit should provide figures on compliance with the guidelines and suggest where there is room for improvement. Data are collected on ward rounds or directly from patients' medical charts. How do you choose which infections to audit? Here are some suggestions. Common infections such as community-acquired pneumonia, UTIs, and SSTIs. When a problem is detected, a specific intervention might be designed. For example, an increase in infections after surgery or in urine cultures referred to the microbiology lab, which might indicate that patients with asymptomatic bacteriuria are wrongly being treated for UTIs. Infections treated for a long duration, for example, more than 7 days. The AMS team pharmacist notes that during the past week, 3 patients admitted to the internal medicine unit with non-severe CAP received a combination of ceftriaxone and clarithromycin. Clinical guidelines at your hospital recommend ampicillin alone for most non-severe CAPs. What can be done? Click the link below to read the recommended solution. During ward rounds or in specific patient consultations, a member of the AMS team has the impression that many patients with urinary catheters are being treated with antibiotics. What can be done? Click the link below to read the recommended solution. To what degree is an antibiotic used according to guidelines? The audit should provide figures on who is receiving antibiotic or antibiotics, indications for treatment, and whether the patient is receiving the right antibiotic treatment. How to choose which antibiotics to audit. Antibiotics where consumption has increased significantly over time. Antibiotics with a higher potential of inducing and propagating resistance, for example, watch and reserve antibiotics. Broad-spectrum antibiotics, for example, piperacillin, tazobactam, tisocillin, clavulanate, carbapenems. Last resort antibiotics, for example, polymyxins, linezolid. Expensive antibiotics. The pharmacist who picks up medication request forms in the ICU has noted that for some time now, there has been an increase in the use of meropenem in higher doses and of colistin. What can be done? Click the link below to read the recommended solution. As part of the stewardship strategy, the AMS team decides to assess what is happening with antibiotic surgical prophylaxis. Your hospital has not yet updated clinical practice guidelines for this indication, but national guidelines are in place. What can be done? Click the link below to read the recommended solution. IT can play a beneficial role in an AMS program. A successful AMS program needs to be adequately measured to be efficient. The use of proper and updated information is essential. Often, data can be collected and analysed without technology. Point prevalence surveys are an example of this. IT can benefit AMS interventions at basic, intermediate and advanced levels. At the basic level, IT can help create database on procurement and ward dispensing at the facility pharmacy level, database of AMR surveillance in different units. At an intermediate level, IT can help in areas such as calculation of antimicrobial consumption, for example, in defined daily dose or DDD per 1,000 inpatients per day, alerts on specific antibiotic use, time-sensitive automatic stop orders for surgical prophylaxis, electronic guidelines, for example, via electronic mailings to prescribers or in the intranet, apps for doing point prevalence surveys. At an advanced level, IT can help with computerized physician order entry system, estimations of clinical outcomes related to antibiotic treatment, apps for national, regional or facility, guidelines, point-of-care access to microbiological results from all units, clinical decision support systems of different levels of complexity, computerized patient dispensing billing data, automatic submissions or reporting of computerized facility-level data to the National Centre. You have reached the end of Module 4. Try to answer these questions to check your understanding so far.